Hi everyone, welcome to this video. In this video, we are going to talk about a very important category of disorders, that is depressive disorders. Now, depressive disorders are in fact one of the common mental illnesses. In fact, one of the famous Hollywood actor, Jim Carrey, whose so many movies made us laugh, he also had suffered from depression and in fact also became well after the treatment. In fact, nowadays there are so many celebrities, sportsmen, they are now coming out and they are saying that they also once experienced depression and they took treatment and now they are doing fairly well. So depression is one of the common mental illnesses. So we'll talk about depressive disorder in this video. Now, let's talk about the overview of the video. First of all, we'll talk about the concept of mood disorder. I'll briefly discuss how we can understand the concept of mood disorders, and then subsequently we'll talk about a very important disorder, that is depression. When we'll discuss depression, we'll discuss the epidemiology, we'll talk about important etiological factors of depression, we'll talk about how to make diagnosis, and very important, especially for exams, we'll talk about some important specifiers of depression. And in the end, we'll talk about the treatment. Treatment again would include drugs as well as therapy. And we'll also talk about some other depressive disorders. So let's understand what are mood disorders. Now in the basics, we have talked about what is mood, what is affect. But here we use this term interchangeably. So mood disorders are also known as affective disorder. Now as the name suggests, the key feature of mood disorders is the abnormality of mood. Now based on this concept, let's try to understand. So there can be two types of abnormalities. First is when the person is appearing sad. So the person is very sad, without any reason the person may appear very sad. So this is one extreme of abnormality of mood. On the other hand, the person may be very, very happy. The mood is elated. It is cheerful. So based on these two abnormalities, we'll discuss the concept of mood disorders. Now also remember, sometimes the mood may also be irritable. What is irritable? Irritable means getting angry on small issues. Now mood disorders, subsequently we have divided into two categories. First is depression. So depression is one of the mood disorders. So we'll talk about depressive disorders in this video. And second is bipolar disorder. Now let's understand what is depression. Now suppose in this diagram, let us suppose that the lower axis is representing sad mood and the above axis is representing the mood is elated, it is very happy or cheerful. Now in depression, the symptoms of the patients include sadness of mood and other symptoms. So the mood is on the lower pole. So this is what is known as depression. So let us say this patient had one episode of depression. Now, it may happen that after some time, the person may have more episodes of depression. So, either the person may have one episode or multiple episodes also the person may have. So, these are subsequent episodes. So, this is what is depression. So, can you appreciate here, all the time we are seeing that the symptoms are on the lower pole. So, these are depressive disorders. Now coming to bipolar disorder, here sometimes the symptoms may be on the lower pole. So this is a depressive episode, so patient may have depression, while on other hand, patient may also have symptoms on the other pole. So when the mood is very happy or it is cheerful. So these episodes we'll discuss in bipolar disorder. These may be episode of mania or hypomania. So again, as you can appreciate, sometimes the patient mood is sad, it is on the lower pole, while sometimes the mood may be on the other side. So this is what is known as bipolar disorder. Now can you appreciate this from the name? Why it is known as bipolar disorder? Because symptoms are present on both the poles. This is bipolar disorder. Sometimes person is happy, sometimes the person's mood is sad. Now, if you appreciate both these disorders, be it depressive disorder or bipolar disorder, what is happening in between? So, we can appreciate that in between the patient's mood is absolutely normal. So, in between the person returns to his normal level of functioning. So we can say that these mood disorders usually are the continuous illnesses. No, these are episodic illnesses. So very important point to understand. So many of the times we see that these disorders are episodic illnesses. They occur in episodes. So whenever a person comes to us, let us say with this episode, always we take a past history whether he was having any other episode in the past or not. So this is the broad concept of mood disorders. So we'll discuss a depressive disorder and then we'll talk about bipolar disorder in another video. Now also remember, when we talk about depression, usually untreated episode of depression, they may last for 6 to 13 months. That means even if we don't treat the patient may become all well in 6 to 13 months. While in bipolar disorder, untreated manic episode may last up to 3 months. So again, that is telling us that these disorders are episodic. Even if we don't treat, the person after some time becomes all well. But of course, we treat because we don't want the patient to suffer. So this is about the concept of mood disorders. Now we'll talk about depression. Now depression is one of the very important topics both for your theoretical exam, even for the MCQ based exam. Now depression in DSM-5 is known as MDD, that is major depressive disorder. So whenever you are given that the person is having major depressive disorder, that means the person is experiencing depression. So it may be called as depressive disorder, and we can also call it unipolar depression. Now, I hope from this diagram we can appreciate why we can call it as unipolar depression, because symptoms are occurring only on one pole. So this sometimes may be referred to as unipolar depression. So when we talk about depression or MDD, here the patient is having only depressive episode. That means there are no other episode, that is manic, hypomanic or any mixed episode. So only patient is having depressive episodes. Now let's talk about the epidemiology of depression. Now first we'll talk about the lifetime prevalence, and lifetime prevalence of depression is 10.8%. So this is basically from the latest Kaplan-Sadok synopsis, and it is found that recent meta-analysis have shown this as to be the lifetime prevalence, while earlier data suggested that it is around 12%. So now remember, it is 10.8%. Now let's talk about most common mental disorder, both in India as well as world. So when we talk about the most common mental disorder in India, if we exclude tobacco use disorders, the answer is depression. So this is according to the National Mental Health Survey, that is NMHS 2015-16 data that was conducted by NIMHANS. So it suggests that depression is the most common mental disorder in India. And when we talk about the most common mental disorder in the world, again, this is according to the surveys by WHO, it is anxiety disorder. So overall, most common mental disorder in the world is anxiety disorder. Anxiety disorder is a group which has various anxiety disorders in it. And individually, if somebody asks most common mental disorder, that is specific phobia. So specific phobia is one of the individual anxiety disorder. And if it is asked second most common mental disorder in the world, it is again depression. So we can see that depression is in fact common. It is a common mental illness. Now let's talk about the prevalence in terms of males and females. It is found that depression is more common in females than males. In fact, the ratio is 2:1. Of course, it can also occur in males, but it is more common in female. And the most common age of onset of depression is 40 years. So if it is asked that depression is more common seen in, so in fact, this is a previously asked question, that depression is more common in young male, young female, middle-aged male, middle-aged female. So remember, it is most common in middle-aged females. Now talking about children, again in children also depression can occur. In children, the prevalence is usually similar in males and females. Now also, when we talk about depression in certain groups, it is found that depression is more common in people who are divorced or who are separated. Now coming to the prevalence in relation to the socioeconomic status, again it is found that there may not be any proven correlation with the socioeconomic status, although some studies have shown that depression is more common in rural than urban population. Now let's talk about one more interesting point about the epidemiology, which is DALYs. What is DALYs? That is disability adjusted life year. So basically it is the disease specific reduction in the life expectancy of the person, maybe because of the disease disability as well as increase in mortality. Now, it is found that out of the psychiatric illnesses, depression has a maximum daily. So again, this is an important data-based question, that maximum dailies in psychiatric illnesses is due to which condition? It is because of depression. So these were some important epidemiological data which we talked about related to depression. Now let's talk about the etiology. Now, as we have been discussing etiology of disorders like schizophrenia, even mood disorder, even depressive disorders don't have one specific etiological factor. Multiple factors play a role in development of depression. So let's talk about some important headings under etiology, and the first important factors we'll discuss are the biological factors. Now, in biological factors, let's discuss neurotransmitters. Various neurotransmitters have been implicated, and in fact there is a theory that is monoamine hypothesis. Now, some of the important monoamines like serotonin, norepinephrine and even dopamine, they are implicated in depression. In fact, it is seen that serotonin, norepinephrine, they are reduced in depression. So if you are asked two important neurotransmitters related with depression, it is serotonin and norepinephrine. In fact, also remember, dopamine is also reduced in depression. In fact, we'll correlate this with the mechanism of action of drugs. So we'll talk about some antidepressants, and there I'll discuss that many of those antidepressants, they have a role in increasing some of these neurotransmitters. So this is how we can always correlate the etiology with the mechanism of action of drugs. Also, other neurotransmitters like acetylcholine is also implicated. In fact, it is seen that cholinergic agonist, they can exacerbate symptoms in depression. One more important neurotransmitter, remember, is GABA. Now, GABA is also shown to be decreased in the levels in plasma, in the CSF, in the brain in patients with depression. So these are some important neurotransmitters which are associated with depression. Now, the second important biological factor which we'll discuss are the endocrinal disturbances. Various endocrinal disturbances has been associated with depression. Now, one very interesting finding which has been found in patients with depression is elevated HPA axis activity. So we know HPA axis, that is the hypothalamus pituitary adrenal axis. In fact, we know from our physiology understanding that chronic stress increases the HPA axis activity, and also this is seen in depression as well. So there is hypercortisolemia which may be seen in many patients with depression, and how we can see this by seeing the urinary free cortisol levels, plasma cortisol levels and the salivary cortisol levels. So it is found that there is elevated HPA axis activity which is usually corresponded with hypercortisolemia. In fact, there is one interesting test we'll talk about, that is dexamethasone suppression test, that is the DST, which will tell us, which suggests that there is an increase in the HPA axis activity. So what is this dexamethasone suppression test? So here the patient is given dexamethasone, which is a potent glucocorticoid, at night. Now normally, because of the negative feedback, we know in normal people there will be decrease in the CRH, that is the corticotropin releasing hormone, subsequently which decreases the adrenocorticotropic hormone and which subsequently decreases the cortisol surge. So there will be decrease ultimately in the cortisol surge after the DST. So this is a usual response. But what is happening in depression, since there is already hypercortisolemia, even after this DST, in depression the cortisol surge does not get suppressed, and this is giving evidence that there is an increase in the HPA axis activity. Now remember, this is not a diagnostic test. It's not that in any patient with depression we will use this test. It does not have very high specificity and even sensitivity. But remember, yes, many patients shows elevated HPA axis activity in depression. Now, one more important endocrinal disturbance is hypothyroidism. Hypothyroidism is also associated with depression. In fact, it is found that many patients who come to us with depression, we take a good history. Sometimes they may also be having hypothyroidism. And if we treat hypothyroidism, many times those depressive symptoms are also improved. In fact, even sometimes subclinical hypothyroidism is also associated with depression, and sometimes thyroxine is used in the management. In fact, we'll talk about in the treatment of depression some augmenting agents. So augmenting agents basically are helping in the treatment by increasing the effect of the first line drugs. So thyroid hormone is also sometimes used in the treatment of depression as a augmenting agent. So we'll talk about this when we'll discuss in the management. So remember, even hypothyroidism may be associated with depression. Now one more endocrinal disturbance is brain-derived neurotrophic factor, that is BDNF. Now BDNF factor is basically required for the maintenance of neurons, and it is found that in depression there is decrease in the BDNF. And in fact, interestingly, when we treat the patient with antidepressant, it is shown that antidepressants subsequently increase the BDNF. So these are some important endocrinal disturbances. Let's discuss the next biological factor, which are the neuroanatomical factors. Now also there are certain areas which are implicated in depression, and one very simple way you can remember, when we talked about in the basics, we discussed some areas related with emotions. We talked about areas which are related with generation of emotion, which is the limbic system, and we discussed one important area which regulates emotion, that is the frontal lobe, especially the prefrontal cortex. So let's subsequently understand there are key areas which are associated with depression. So as we have discussed, limbic areas like amygdala, there is hippocampus, there is also anterior cingulate cortex, and also remember the prefrontal cortex. So these are some important areas implicated in depression. In fact, if we see structural changes, one of the most consistent structural finding which is shown on imaging like MRI is hyperintensities in the subcortical regions. Hyperintensity is subsequently corresponding to degeneration. So there is degeneration in certain subcortical regions like the periventricular regions, basal ganglia and thalamus. So in fact, this is the most consistent abnormality which is seen in patients with depression in the structural imaging. Also remember other areas like there is also decrease in the hippocampus. So there is decrease in the volume of hippocampus, and even amygdala has also shown decrease in the structural imaging. So these are some important structural abnormalities. Also when we talk about functional abnormalities, again the most consistent finding on PET scan in patients with depression is anterior brain metabolism is reduced, where left is more involved than right. And how to remember? You can remember it like this. In depression, the mood is low. Remember, L for low, L for left. So there is decrease in anterior brain metabolism more on the left side than the right side. So in fact, the prefrontal cortex, PFC, also shows decrease in the metabolism. And in the functional imaging, the limbic structures, they have shown increase in metabolism. So you can see even there are structural functional changes also occurring in patients with depression. So these were some important biological factors of depression. Now let's talk about the genetic factors. Family studies, twin studies have shown that yes, genetic factors do play a role. In fact, when we talk about mood disorders, if one parent has a mood disorder, the risk of the child developing mood disorder is around 10 to 25%. If both the parents have mood disorder, the risk nearly doubles to 50%. Also, more the number of family members having mood disorder, the risk further increases, especially for bipolar disorder. Family history of bipolar disorder increases the risk further. In fact, when we talk about depression, the heritability of depression is 37%. That means that genetic explains around 37% of the etiology in depression, and this is higher in women. So genetic factors may play more role in women. While if we compare it with bipolar disorder, in bipolar disorder, in fact, the heritability is 75%. So 75% of the etiology of bipolar disorder is explained by genetics. Now, when we talk about genes, there is no one specific gene associated with depression. Many genes have been identified. Let's discuss one important gene, which is a serotonin transporter gene, that is SLC6A4. Again, you can appreciate again serotonin seem to play a role in depression. Now, this gene has a promoter region with two alleles. There is a short form and there is a long form. Now, it is seen that person with a short form allele if he has a negative life event in his life, for example, there is death of a close family person or any other negative life event, it increases the risk of depression. In fact, this is the first gene to show interaction of genetic factors and environmental factors leading to depression. While people with long form of allele, they have lesser symptoms and also show better response with drugs like SSRI, selective serotonin reuptake inhibitors. Now let's talk about some psychological theories of depression. So there are certain theories which have been proposed. Let's discuss some important ones. First and very important is the cognitive theory of depression, which is given by Aaron Beck. So sometimes this is asked that cognitive theory is for which disorder? It is for depression. Now, what is this theory? Cognitive means thoughts. So all of us normally have some automatic thoughts which come in our mind. So right now also, if we sit silently, there may be some thoughts which may come automatically in our mind. For example, thought may come like this: what should I eat after this video? What should I do in my free time today? So these are automatic thoughts which occur usually. Now, according to Aaron Beck, in this theory, patients with depression, they develop cognitive distortion. Cognitive distortion, basically these are negative patterns of thinking. So these are negative, inaccurate ways of thinking. So we discussed that normally we have automatic thoughts. Patient with depression, they may have these automatic thoughts as negative. So there are automatic negative thoughts. So basically these patients, they have a biased interpretation of life events around them. So they may have automatically negative thought. Patient may sometimes come and say, sir, without any reason, I am having so many negative thoughts. So this is the basic understanding of this theory. Now let's talk about some important cognitive distortions, some automatic negative thoughts or some negative patterns of thinking which may be seen in patients with depression. First is arbitrary inference. As the name suggests, drawing a specific conclusion without any sufficient evidence. So patient is making an arbitrary inference without any specific evidence. For example, a patient may have such thoughts like, everyone can tell that I am a loser. So such kind of cognitive distortions can occur in the person. Now, of course, this is wrong, because how would a person know what everybody is thinking? And why would everybody be thinking about him? So this is arbitrary inference. Then another cognitive distortion is specific abstraction. Again, as the name suggests, here focusing on a single specific detail while ignoring the other more important aspects of an experience. For example, a person gave lecture and everyone applauded that person, but he received one feedback which gave a poor rating to him. And he started having this thought that I am a bad speaker. So what is happening here? Here he is focusing on a single detail while ignoring the other important aspects of the experience. So this is specific abstraction. Another cognitive distortion, as the name suggests, overgeneralization. So now the person is forming conclusion based on a single event. For example, student does bad in one grand test and then he starts thinking that I am going to fail in all the exams. So he has overgeneralized. He has applied that result to all the other tests as well. So this is overgeneralization. Next is magnification and minimization. So basically here there is error in the evaluation of the event. So what is magnification? As the name suggests, focusing on the worst possible outcome, overvaluing an experience, or you can say blowing things out of proportion. This is magnification. For example, a person gets 2 marks less in the Viva and the person, what he's saying, he says that this is my worst result ever. So he has basically blown things out of proportion. This is magnification. Now next is minimization. Minimization, as the name suggests, undervaluing or minimizing the importance of an event. For example, a student was told to study, otherwise he'll fail in the final exam. So a lot of professors said him this, and what he's thinking, I don't know why they are all so worried. So he's undervaluing, he's minimizing the importance of an event. So this is magnification and minimization. Next is personalization. Again, as the name suggests, personalization means self-reference external events, no basis of such connection, so thinking that the external events are related to me. For example, the person says my friend failed in the exam because I couldn't give my notes a day before the exam. So what he has done, he has basically self-referenced the external event, because of course the friend has not failed because of him. The friend has failed because he has not studied well. So this is personalization. Next is absolutist or dichotomous thinking. So here basically the person is thinking in extremes. So it is also known as all or nothing thinking, or seeing things as all black or white thinking. So for example, a person says that you didn't pick my phone, you are the worst person I know, get out from here, I don't want to see your face. And to the same person, next day the person says, oh, you helped me in making my notes, you are my angel, what would I have done without you? So here, as you can see, the person is seeing either all the good qualities or all the bad qualities in a person. So this is what is meant by absolutist or dichotomous thinking. So these are some important cognitive distortions that can occur in patients with depression. In fact, when we'll talk about therapy, we'll talk about cognitive behavior therapy, a therapy used in depression. So CBT has one aspect of cognitive therapy wherein we identify these cognitive distortions in the patient and we try to correct them. So this is the cognitive theory. Now also, when you're talking about Aaron Beck also gave a triad for depression, which is known as cognitive triad of depression. So Aaron Beck said that patient with depression, they have negative views about themselves. So patient may have negative thoughts like I'm a bad person, I'm a bad mother, I'm a bad father, I'm worth nothing. So this is also known as worthlessness. Patient may have negative views about the environment. That environment is very harsh. There is no one who can help me. I feel helpless. So this is known as helplessness. Then patient may have negative views about the future. Tomorrow is very dark. Who has seen tomorrow? Everything is so bleak for tomorrow. So there is no hope for the future. This is known as hopelessness. So worthlessness, helplessness and hopelessness. This is the cognitive triad of depression, again given by Aaron Beck. Now let's discuss the next psychological theory, which is learned helplessness. Now this theory basically comes from an experiment which was conducted on dogs. So basically the dog was put in a situation wherein he was given mild electric shock, but he could not escape the situation. So even if he tried to attempt and go out, he could not, and he was receiving electric shock. Now the same dog, if is kept in another situation where there is a lever, and if he pulls the lever, he can go out of the situation, and again he has been given electric shock in this situation. Now it was found that this dog did not attempt even to go out to escape, as if he has learned to be helpless. So this theory connects depression to the experience, past experience of uncontrollable adverse events. So basically it is related with the belief that it is futile to initiate any personal action in a aversive situation. So this is learned helplessness. So here it makes the patient to believe that there is no sense of control, that I cannot control my external environment, and subsequently there is loss of motivation to act. So this is learned helplessness. Now also let's talk about some psychodynamic theories related with depression. The first is, it is postulated that depression is related with disturbance of infant-mother relationship during the oral phase. Oral phase we will discuss in psychology, it is from birth till 18 months. So it is found that there is disturbance of the infant-mother relationship during this phase, which increases the vulnerability of depression. Also, depression has been linked to real or imagined object loss. So separation from a significant object of attachment, that also may lead to risk of depression. Also, one interesting defense mechanism is introjection, which is associated with depression. Now there is introjection of the departed object. So the object lost, the departed object, the person has a mixed feeling, the child has a mixed feeling of love and hate of that departed object. So what is introjection? The child basically introjects the feeling of that object in him. So there is feeling of anger. Now this anger is directed inwards towards self. So remember, introjection is one of the defense mechanisms which is related with depression. So these are some important psychodynamic theories of depression. Now let's talk about the environmental factors. There may be certain factors in the environment, certain life events which may also increase the risk of depression. Now there are two different questions. Let's understand. First is most often life event associated with the development of depression. That means in future the person has a risk of developing depression. That life event is losing a parent before the age of 11 years. So that increases the risk of depression later on. While if it is asked that most often the life event associated with the onset, that means after this event the depressive episode may occur. So that is a loss of spouse. So these are again some adverse effects, adverse life events which can increase the risk of depression. Then there may be other events, for example, unemployment, loss of job. These factors may also increase the risk of depression. So these were some important etiological factors related with depression. Now let's understand what are the symptoms of depression. So suppose a 24-year-old male, he had a breakup. And now since the past 4 days, he is appearing very sad. He is not meeting people. He is just sitting in his room alone, crying and listening to Arijit Singh songs. But on the 5th day, he is into another new relationship and now he's all well. So was he suffering from depression? So let's understand how to make a diagnosis of depression. So we can remember the symptoms of depression with this mnemonic, SIGE caps with double S. So the first symptom, so remember it's a mood disorder. So first symptom we'll discuss, the mood of the patient is sad or it is a depressed mood. But it is not the normal sadness we often sometimes experience. In this sadness or in this mood, the person is sad most part of the day and most of the places. So for example, a 35-year-old female says since the past 2 months, she is feeling sad and this sadness is occurring most of the time in the day and most of the places. So this is sad or depressed mood. Second symptom is I. What is I? I is interest. So there is reduced interest. This is known as anhedonia. So this 35-year-old female says that in the past 2 months now I have reduced interest in shopping. I don't enjoy shopping anymore. I don't enjoy going to kitty parties. So person has reduced interest in activities which the person used to enjoy before. Now sometimes when the people observe, the patient may appear socially withdrawn, and also sometimes patient report of decrease in sexual interest or sexual desire as well. Next symptom is G. G is guilt or worthlessness. Patient may have negative views about the self. For example, the person may think that I am a bad person, I am a bad mother, I am a bad father, I am worth nothing. So this is known as worthlessness. So patient has negative views of self. Then E is energy. What happens to energy in patients with depression? The energy levels are reduced. So this is also sometimes referred to as easy fatigability. So patient says, I get tired easily. If I do just half of the work which I used to do earlier, I get tired. And sometimes patients say, I'm just sitting and by sitting only I feel tired. So there is reduced in energy. So this is SIGE. Let's discuss some other symptoms. C is concentration. So we know concentration is sustained attention. So there is reduce in the concentration of these patients. Now often these patients present to us with a very typical complaint. So this 35-year-old female may come to us with this complaint of forgetfulness. So patient says that I forget where I've kept my keys, important documents. Sometimes I'm talking to someone and during the conversation I forget what is being talked about. Now this forgetfulness, it may appear like there is some memory loss. So please remember here, this problems in remembering things is not actually amnesia. Here the patient is having reduced concentration. For example, the person has put the pen inside her pocket and now the person is looking in the home searching for the pen, because during that time there are a lot of negative thoughts. The patient did not pay attention that where the patient has kept the pen, and now the person thinks that I am forgetting things. So this is also sometimes referred to as pseudo dementia. So pseudo dementia is seen in depression. Again, we don't have to treat it separately. If we treat depression, this will also improve. Then A is appetite. Now, what happens to appetite? Now, appetite is one of the biological functions. It's important to understand that in depression, there are a lot of biological symptoms. For example, changes in sleep, changes in appetite, these are seen. Now, in depression, many of the patients report that my appetite has reduced. I don't feel like eating anything, and subsequently, their weight may reduce. But there are a small section of patients in depression also who may also report the opposite. They may say that my appetite has increased and subsequently that my weight is increasing. Sometimes we also do when we are emotional, we go in the kitchen and we start eating whatever is present. So we do sometimes emotional eating. So remember, appetite can also increase in depression. Now, basically, the significant weight change is considered when it is more than 5% in a month. So it is reduced or it may be increased. So there are changes in appetite. Next is P. P is psychomotor activity. Psyche means mind, motor means body. So the psychomotor activity also is disturbed in patient with depression. So it may reduce, psychomotor activity can reduce in the form of psychomotor retardation. So we may see that there is reduced in the thinking of the patient. So patient may speak slowly, patient may walk slowly, may do movements very slowly. So there is reduction in the psychomotor activity. But sometimes again, in patients with depression, there may also be opposite. The psychomotor activity may also increase. Sometimes we see that the patient having depression is very restless, is not able to sit at one place, is continuously moving around. So it may also increase. Now, next symptom is S, that is sleep. Now, again, in depression, there are changes in sleep. As we discussed, biological functions are also affected. Now, again, sleep may be affected in two ways. Many of the patients come with this complaint that my sleep is reduced, that is known as insomnia. Now, also it's important to remember when we talk about insomnia, it can occur in various ways. Now, many patients report that the quantity of my sleep has reduced. So, I am sleeping less than before. And some patient may also report of quality of sleep has reduced. So patient may say I am sleeping for the duration which I used to sleep before, but when I wake up in the morning, I don't feel fresh, as if the quality of sleep was not well. So it can occur in both ways. Now let's understand some important findings which we see in patient with depression with insomnia. Many times these patient reports of multiple awakening during the night time, and often we see that patients have early morning insomnia, often referred to as terminal insomnia. So that means the patient report that I am waking up at least 2 hours before my usual time. So normally I do wake up at 8 o'clock in the morning. Now the patient says I am waking up 6 a.m. or before that. So this is known as early morning or terminal insomnia. Now, in sleep architecture, if we see in depression, there is reduction in the NREM, especially N3, which includes the previous stage 3 and 4 of sleep. So, there is reduction in NREM and there is increase in the REM, especially in the first initial part of sleep. Now, also interesting finding is that there is reduced REM latency in depression. Now, what is REM latency? Let's try to understand this. So, when we are awake and then we go to sleep. Now, when we fall asleep, the first stage we encounter is the NREM, and after some time, we encounter the first REM, and then again there is NREM and then it is repeated REM. So, the first REM, the time it takes from NREM to first REM, this period is known as REM latency. Usually we say it is 90 minutes. So when we fall asleep after NREM, the first REM appears in 90 minutes. But in depression, this is reduced. That means in patient with depression, this REM may occur before, maybe in 30 minutes, 20 minutes. So there is reduction in the REM latency. So these are some important findings in insomnia seen in depression. Now again, some patients may report the opposite. So many patients with depression may also complain that my sleep is increased, that is hypersomnia. Either they may report that they are sleeping more in the night time, or they may also report that during the daytime also they sleep. So remember, changes in sleep can occur both ways. There can be reduction in sleep, there can be increase in sleep. Now the next S is suicidal thoughts or act. Patient may report of having suicidal thoughts, or they may even attempt suicide. Sometimes patient may have a plan, they may plan how to attempt suicide, or sometimes they may just have death wishes which are passive. So they may just have wishes that, I don't just wake up in the morning only. So these are the important symptoms of depression. Again, you can remember it with the mnemonic SIGE CAPS. Now let's understand how to make a diagnosis. Now the diagnostic criteria according to DSM-5 says that out of these symptoms, 5 or more symptoms should be present, and importantly, remember at least one symptom should be from first two. What are the first two symptoms? That is sad mood and decreased interest. So you can remember it like this, that out of this, at least one of the first two symptoms should be present plus 4 or more of the remaining symptoms. So total of 5 symptoms should be present. And what is the duration? The duration is at least 2 weeks, that is 14 days. Then we make a diagnosis of depression. Again, it's a depression, it's a disorder. So there is also clinically significant distress, or there is reduction in impairment, or there is impairment of functioning of the patient. That means their social, occupational or other areas of functioning are also affected. Then we make a diagnosis of depression. So this example, let us say the patient, so this patient, 35-year-old female, since the past 2 months is feeling sad most part of the day, most of the places, has reduced interest, the energy levels are low, she is also having forgetfulness, decrease in concentration, and she wakes up 2 hours before her usual time. So what is the diagnosis here? The diagnosis is yes, it is depression. So this is how we make a diagnosis of depression. Now let's understand what is a recurrent depressive disorder. As the name suggests, it means that there are 2 or more episodes of depression. In DSM-5, it is also referred to as MDD recurrent. So patient is having at least 2 or more episodes of depression. So let's take an example. Suppose a patient comes to us with this episode, and when I take a past history, the patient also have a previous similar episode. So the previous episode was the first episode, and now the patient has come to me with the second episode. So now the diagnosis which we will make is recurrent depressive disorder. Also remember, when do we consider that another episode, it's a new episode? When at least a minimum duration of 2 months should be there between 2 episodes, when the person has become absolutely normal. So as you can see here, in between, for more than 2 months, the person is normal. Then I will consider it as a new episode. Suppose in another situation, a patient comes to us with depression and we treated the patient, and after a month, patient again develops similar symptoms. So now will I consider this as a new episode or the same episode? I will consider it as the same episode, because we are saying that at least for 2 months, the patient should be all well in between. Then only we will consider it as a new episode. Now let's talk about specifiers of depression. Now when we say specifier, that means we have made the diagnosis of depression. So my patient is being diagnosed with MDD, but sometimes patient may have some additional or some unique features, and we add it as a specifier. So we say that the patient is having depression with whatever unique features the person is having. So let's understand some important specifiers of depression. First, we'll talk about depression with psychotic symptoms. So patient is being diagnosed with depression. So the primary diagnosis is MDD or depression. Along with this, patient may also develop delusions or hallucinations. So then we say patient has psychotic depression. Now sometimes these psychotic symptoms may be categorized into 2. One is psychotic symptoms which are mood congruent. So mood congruent means that the content of these delusions or hallucination is consistent with the themes of depression. For example, a patient with depression reports that I don't exist, my family does not exist, the world does not exist. So he has developed delusion of nihilism. So patient is having delusion of nihilism. Again, this is in line with the theme of depression. Patient may report that I am the thinnest person in the world. So patient has developed guilt, which is up to a level of delusion. So these are delusions of guilt. So here the patient has developed psychotic symptoms which are in sync with the theme of depression. Similarly, a patient may report that he is hearing voices. So this is auditory hallucination, and they are saying that he is a bad person. So again, these are in sync with the theme of depression. So this is mood congruent psychotic symptoms. while there is something known as mood incongruent psychotic symptoms, wherein the theme of or the content of delusion hallucination is inconsistent with the themes of depression. For example, a patient having features of depression says, I am the richest person in this world. So he has developed a delusion of grandiosity. So can you appreciate here, the content of delusion is not in theme or not in line with the content or with the theme of depression. So this is mood incongruent psychotic symptoms. Now let's understand three clinical scenarios. So we'll discuss three situations and we'll be able to differentiate three important entities with this example. So let us say we have patient A, and let's say that the duration of the symptoms of these patients, let us say it is 8 months. Now in this we can appreciate that for the past 8 months the patient is having delusions, hallucinations, and for 2 weeks in between the patient also has developed depressive symptoms. This is patient number A. Patient number B again has delusions, hallucinations for 8 months, and for around 7 months patient also has depressive symptoms. While patient number C, he has depressive symptoms for 8 months. So throughout the illness depressive symptoms are present, and in between, let us say for a few days or weeks, he has also developed delusions, hallucination. So let's see the diagnosis of each of these patients one by one. Now patient number A, we see that primarily the patient is having psychotic symptoms, and just for less duration they are depressive symptoms. So we can say that this patient is diagnosed with schizophrenia. Now when we see patient number B, for majority part of the illness, patient has both schizophrenia like symptoms and mood symptoms, and there is also in between 2 weeks at least in which patient is only having delusion, hallucination. So this we have learned from our knowledge of psychotic disorders. This is schizoaffective disorders. While if we see patient number C, throughout the course of illness patient is having a depression, and for a small duration in between he's also developed psychotic symptoms. So here we can say that the primary diagnosis is depression, and along with depression now the patient has developed psychotic symptoms. So it's very important to differentiate these three entities. And again you can appreciate that in schizoaffective disorder we are saying that there was a time period in between for at least 2 weeks. DSM-5 says that there is only delusion, hallucination. So this again helps us differentiate from mood disorder like depression with psychotic symptoms, because when we make a diagnosis of depression, then depressive symptoms should be present throughout the course of illness, like in this example patient number C. Now when we talk about these additional features, these specifiers, so what is the importance or why we are adding these specifiers? Because these specifiers will also have an impact on the treatment. So when we treat depression, we'll discuss, we have antidepressants, we have therapy. Now this patient who is having depression with psychotic symptoms, so along with antidepressant, would I add anything else? Yes, even antipsychotics are added. So you can say that they are also having an effect on the management. Also it is seen that sometimes these patients may also have shown good results with ECT. But of course, initially we will give antidepressants with antipsychotics. Now also remember, when we talk about ICD, ICD-10 used to add the specifier of psychotic feature only with severe depression, while ICD-11 now says that this specifier can also be used even for moderate and of course as well as severe depression. We'll discuss how to differentiate mild, moderate and severe depression. Now next specifier which we're going to discuss is depression with melancholic features, also sometimes referred to as involutional melancholia or melancholic depression. Now basically this term melancholia is a Greek word for black bile. So again, quite long time back, initially it was thought that this melancholic depression is because of some endogenous factors, because of some biological factors. So remember, often sometimes it is referred to as endogenous depression. That means there is absence of any external stressors or any external negative life events. Now this melancholic depression often, represents a more severe form of depression and usually is seen in old age, of course, but can also occur in young age as well. So let's understand some of the unique features of this melancholic depression. Here there is loss of pleasure in nearly all the activities. So all the activities the person has lost pleasure, or there is lack of reactivity to pleasurable stimuli. Sometimes in depression, for a transient movement, patient may have, reactivity to some pleasurable stimuli. But here in melancholic depression, there is lack of reactivity to all the pleasurable stimuli. Also, patient may have some other features in melancholic depression. Now, patient may have a very severely depressed mood. So, patient may have a profound despondency, despair, or sometimes referred to as empty mood. So, the mood is severely depressed. Then patient may also have various biological symptoms. For example, early morning awakening. So, insomnia is there. So, early morning awakening is seen, getting up 2 hours at least before the usual time. And patient may report that my mood is worst in the morning. So, patient with melancholic feature often say, when I wake up, that is the worst time of the day. By the evening, things may improve, but mood is worst in the morning. Also, in biological symptoms, there is reduce in appetite. Patient may have weight loss. Patient may also have excessive guilt. So, patient may have a out of proportionate guilt. Patient may say, I am the sinnest person. So, there is excessive guilt. And there is also changes in the psychomotor disturbances. Again, that may decrease or that may increase. So, these are some important features of melancholic depression. Also, when we talk about the suicide risk, usually we'll discuss in depression, the risk of suicide is increased as compared to general population. But especially in melancholic depression, we see that the risk of suicide is high. In the treatment, of course, we'll discuss the drug of choice for depression are SSRI, but studies have shown that sometimes SNRIs may show good results in patients with melancholic features. But of course, we say the drug of choice is SSRI. Now, let's talk about another specifier, which is depression with atypical features. Now, again, as the name suggests, here the person is having features in depression which are not commonly seen in patients with depression. So, these are uncommon or atypical features. Again, I'll give you one mnemonic. Usually, if I ask you, how is the willpower of the patient with depression, you'll say, sir, it is reduced, low. But since it is atypical, so the mnemonic is patient says, my will high. So, let's remember the features of atypical depression with these mnemonic. So, M is mood reactivity. Now, usually we see that patient in depression, their mood is low most of the time, most of the places. But here, since it is atypical, here it is mood reactivity seen. That means mood brightens in response to positive event. If there is some positive event, there is a party, for some time, their mood brightens up. Now, also, we have talked about biological symptoms. So, W is weight. Now, usually we know that in most of the patient, there may be reduce in appetite, reduction in weight. But since it is atypical, here there is weight gain, there is increased appetite. Again, coming to sleep, we know that most of the patient will complain of insomnia. Some may complain of hypersomnia. So, it is atypical. Here, H for hypersomnia, there is increase in sleep. Let's discuss two more symptoms. One is I, interpersonal rejection sensitivity. Interpersonal means between relationships. So, these patients, they are sensitive to events. They feel hurt or rejected by others. Even neutral things would hurt them. So, there is interpersonal rejection sensitivity. They are sensitive to rejection. And L is laden paralysis. So, they would feel as if their extremities, their hands, their legs, they are laden with something very heavy and they are not able to move. So, this is laden paralysis. So, the limbs feel very heavy as if they are paralyzed. So, these are the features of atypical depression. My will high. Now, again, coming to the treatment, it is seen that these patients respond well to drugs like SSRIs, MAO inhibitors, and even bupropion. But TCAs, tricyclic antidepressant, usually are not seen to show good response in these patients. So, again, you can see that these symptoms may affect our decision in management. Next specifier is depression with catatonia. So, we have already discussed when talking about schizophrenia what are catatonic symptoms. So, here along with depression, patient has also developed catatonic symptoms like stupor, there is waxy flexibility, mutism, posturing. So, such catatonic symptoms are there. Now, when we talk about treatment of depression, we can give drugs like antidepressant, but for catatonic symptoms, we know treatment is lorazepam and even ECT can be given. So, of course, in the management, we'll use both antidepressant as well as we'll treat catatonic symptoms. But suppose in the question they say that a patient is having depression with catatonic symptoms and one option is antidepressant and one option is lorazepam, and no option is there in which combination is given, then we may choose lorazepam ECT. That means they are asking about management of these catatonic symptoms. Now let's discuss the next specifier, which is depression with postpartum onset. So it is also referred to as postpartum depression. That means depression occurring during pregnancy or after delivery. So DSM-5 says that onset of depression within 4 weeks of delivery, while ICD-11 says that it can occur up to 6 weeks of delivery. So you can remember patient developing depression during pregnancy or within 6 weeks of delivery. In fact, sometimes it is considered even up to 3 months of delivery. Now DSM-5 in fact uses this term peripartum onset, since we are saying it is occurring during pregnancy or after delivery. So this is postpartum onset. Now again, why we are adding this specifier? Because we know that during pregnancy, after delivery, there are a lot of changes in the body of the female. There are hormonal changes, there are physiological changes, and even there are so many social changes. So these may have some role in the depression. In fact, we'll study this topic separately when we'll discuss some important conditions associated with pregnancy. So one of the conditions we'll also discuss again, postpartum depression. Now let's talk about the next specifier, which is depression with seasonal pattern. As the name suggests, there is a regular temporal relationship between onset of depressive episode and a particular time of the year. So depression is occurring in a particular season. For example, sometimes we see that depression may occur in winters or fall. So this is depression with seasonal pattern. So depression is most of the time occurring in a particular season, and when that season goes away, the person usually becomes normal. Again, remember here we do not include cases with obvious effect of seasonally related psychosocial stressors. Sometimes there may be certain stressors which may occur in a particular season. For example, seasonal unemployment. Patient may become unemployed, let us say, during winters, and that may lead to depression. So there we will not call it as a seasonal pattern, because their depression is occurring because of some other factors. So this is depression with seasonal pattern. Again, what is the benefit of adding such specifiers? We'll discuss. In such patient, light therapy or phototherapy may also show good results. Now let's also discuss about the severity. We can divide depression into 3 severities. One is mild, moderate, and severe depression. So let's understand how to differentiate. Now when we talk about the symptoms, so here we are fulfilling the criteria of depression. We discussed 5 symptoms at least should be present. So symptoms are few, maybe just which is necessary to make the diagnosis. While in severe depression, the symptom will be excess of what is required. Sometimes patient may have all those symptoms. And when we say moderate depression, it would be in between mild and severe. Now coming to intensity of symptom, again we can say that the intensity of the symptoms in mild, they are distressing, but still the patient, these symptoms are manageable. While the intensity of symptoms in severe depression, they are seriously distressing and they are unmanageable for the patient. In moderate, it will be something in between. And lastly, very important, when we talk about the functioning. So functioning, there is minor impairment, there is impairment, but the impairment is very less. So the functional impairment is less, while severe depression, the impairment in functioning will be marked. For example, they may give you 2 cases, patient A and B. Both of them are having depression. Patient number A goes to the office, but is not able to manage work, while patient number B has stopped going to the office only. Again, in both the situation, you can see that they are having impairment in their functioning. Here, it is occupational functioning. But patient number A has less impairment, while patient number B has marked impairment. So again, based on these also we can differentiate. And person with moderate depression will be having functioning in between. So this is how we differentiate into mild, moderate and severe depression. Now also previously, in olden times, depression was also divided into 2. One was endogenous depression and another is exogenous or reactive depression. As the name suggests, endogenous means it is caused by biological factors. For example, neurotransmitters, endocrinal factors are there. Usually there is no precipitating event, no negative event or life event is there. And many of the times, as we have discussed already, melancholic features may be seen. and even psychotic features may be seen in endogenous depression. While exogenous or reactive depression, as the name suggests, here it is caused by some psychological factors. So you will see in the patient history that there is some precipitating event, a negative life event may be present. For example, death of the spouse, or there is loss of job. Such stresses may be given, and such patient may also complain of multiple somatic complaints. They may complain of headache, abdominal pain. Such somatic complaints may also be seen in the patient. So this is an older way of classifying depression. Now coming to suicide, 10 to 15% of patients, they commit suicide. In fact, it is seen that nearly 2/3 of the patient, they contemplate about suicide, and it is around 10 to 15% who actually commit suicide. And if it is asked most common psychiatric disorder associated with suicide, again many psychiatric disorders like schizophrenia, bipolar disorder, and so many other disorders we will discuss, they are associated with suicide. But the most common disorder, psychiatric disorder associated with suicide is depression. Now let's discuss some physical signs. So usually in psychiatric disorders, we often see the symptoms, we ask patient symptoms, but sometimes there are also various signs. So let's discuss two physical signs which is seen in depression. So let's see this patient. Can you appreciate some abnormalities in this image here? So what is this known as? This is known as Varagut's fold. So what is Varagut fold? If you can appreciate, there is a triangular fold in the nasal corner of the upper eyelid. Now this occurs because of changes in the corrugator and the zygomatic facial muscles. Because of tone changes in these facial muscles, this sign may appear. So this is known as Varagut's fold. Now next is another interesting sign. If you see the forehead, what is this sign? So this sign is in fact omega sign. So omega sign, you can appreciate there is a omega shaped fold on the forehead above the root of the nose. Again, this is due to excessive use of the corrugator muscle. So sometimes such physical signs may also occur in depression. Now let's also discuss about poor prognostic factors of depression. Now when we say prognosis, prognosis means outcome. Nowadays we talk a lot about these prognostic factors, whether there are some factors which may tell us that the prognosis may be good, and some factors may tell us that the prognosis may be poor. Some of the negative indicator or poor prognostic factors of depression include comorbid dysthymic disorder and MDD. We'll discuss under depressive disorder. There is another interesting disorder known as dysthymia. Now, dysthymia basically is a chronic form of depression wherein symptoms are present for at least 2 years, and the symptoms are usually milder depressive symptoms, but they're present for a long time. So if a person has MDD and dysthymic disorder, that is having a poor prognosis. Then if a person has substance use disorder, for example alcohol, tobacco, again that is suggesting poor prognosis. Presence of anxiety symptoms, again remember sometimes even anxiety symptoms may also occur in patients with depression. So patient may have depressive symptoms and anxiety symptoms. So again that is having poor prognosis. More than one episode, so if the person has more than one previous episode, that is also suggesting a poor prognosis. So usually recurrent depressive disorder. Then males also carry a poorer prognosis. Then some good prognostic factors would include if the symptoms are mild or there are no psychotic symptoms, the hospital stay is short, that also would carry good prognosis. Also remember advanced age of onset, that also carries good prognosis. Good social support, that will again carry good prognosis. So these we have discussed some important poor prognostic factors of depression. Now let's talk about the treatment of depression. And when we talk about the treatment, we have two modalities of treatment. First is we'll talk about pharmacotherapy, that is drugs, and another is psychotherapy. Now in pharmacotherapy, one of the main treatment modalities are the antidepressants. Now when we talk about antidepressant, it is seen that usually they may take 3 to 4 weeks for the onset of action. So theoretically it is said that it may take 3 to 4 weeks for the effect to start. But clinically we have seen it can start even earlier. In fact, we'll discuss later on that now there are newer drugs which have a rapid onset of action. The action may start within 24 hours of administration. Now, when we talk about which drug to choose, usually we see in a broader sense, majority of these drugs may have similar efficacy. So the drug is chosen according to the side effect profile. So whether the drug is better tolerable for the patient or not. Now, when we talk about the duration for how long the treatment should be continued, so if the patient has shown a good improvement with the drug is maintaining well, we say that the treatment should be maintained for at least 6 months after there is improvement, or the length of previous episode, whichever is greater. So if the previous episode was, let us say, 8 months duration, so then we'll continue for 8 months. Now also there is something known as maintenance or prophylaxis. Basically, we sometimes give medicine to prevent or decrease the intensity of future episode as a prophylaxis. So usually prophylaxis is done if a person is having 3 or more episodes of depression. So patient is having recurrent depression. So sometimes when the patient is stable, then also we continue drugs to prevent future episodes or decrease the intensity. Also, if the depression is chronic depression is when the depression is longer than 2 years. Usually we have discussed that depression, it occurred as episodes, but sometimes some patient may have depression for a longer time. Chronic depression, again, we may start maintenance or prophylaxis. Now let's discuss the first group of drug, which are the SSRI, that is selective serotonin reuptake inhibitor. And as the name suggests, these drugs are increasing serotonin levels. Again, we can correlate this with the etiology. We discussed that serotonin is reduced, so these are increasing serotonin. In fact, these are the first line drugs. So usually when a person comes to us with depression, these are one of the drugs which we start, and in fact they are the drug of choice for depression, again because of better tolerability. Let's discuss some important SSRIs. So SSRI like sertraline, fluoxetine, paroxetine, citalopram, escitalopram, vilazodone, fluvoxamine. So these are some important SSRIs. Now let's discuss some important points of these drugs. Now escitalopram in fact is the most serotonin selective drug out of all these drugs. Now coming to vilazodone, in fact vilazodone has a slightly different mechanism of action. In fact it is a SPARI drug. What is SPARI? So it is serotonin, PA is partial agonist. So it is a partial agonist at 5-HT1A and reuptake inhibitor. So it has a serotonin reuptake inhibitor property. Also it is a partial agonist at 5-HT1A. Coming to fluvoxamine, now fluvoxamine is one of the SSRIs which is used for OCD and usually not used for depression. Now let's talk about the side effects of SSRI. Now again, many of these side effects, they may occur initially, and with time the person becomes tolerable to the side effect. And also one of the ways to decrease these side effect is to gradually start the drug. So don't start at a higher dose, gradually increase the dose. Now first are the GI side effects which we'll discuss. In fact, GI side effects are one of the common side effects with SSRI. Nausea is in fact one of the most common side effect. Then other GI side effects like diarrhea, anorexia, dry mouth. Again remember, dry mouth may be seen with SSRI. Constipation may occur with drugs like paroxetine because of anticholinergic property, and also weight gain can be seen with SSRI. Now coming to the CNS side effects, patient may report of anxiety, sleep disturbances may also be seen. There may be insomnia, and some patient may even have sedation. A very interesting side effect is vivid dreams. Sometimes patient on SSRI comes and says that he's having very vivid, strange dreams. That can occur as a side effect. Sweating can occur, emotional blunting can occur, seizures also may be seen, and sometimes even EPS, extrapyramidal symptom, which we discussed in detail with antipsychotic, they may also occur. Then coming to the sexual dysfunction. So sexual dysfunction, in fact, they are the most common side effect with long-term treatment with SSRI. So if we continue the drug for a longer duration, sexual dysfunction may be more common. So sexual dysfunction like decreased libido, sexual desire, delayed ejaculation, inhibited orgasm, these may occur. In fact, delayed ejaculation is a side effect which we use in the management of premature ejaculation. as this will increase the ejaculation duration in PME. Now also it is seen that sometimes patient may stop the medication in between due to side effects. And if it is asked the most frequent side effect associated cause of premature medication discontinuation, it is sexual dysfunction. So because of sexual dysfunction, many times patient may stop the treatment in between. Then there may be hematological side effects. So there is functional impairment of platelet aggregation. So in fact, there is a risk of GI bleed, especially with drugs like non-steroidal anti-inflammatory drugs. And many times we give proton pump inhibitors to reduce the risk. Certain miscellaneous side effects can also occur like hyponatremia, especially in elderly age person. Allergic rashes can occur and even hyperprolactinemia may also be seen with SSRI. So these were some important side effects with SSRI. Now let's talk about another drug, that is vortioxetine, relatively a newer drug, and it has a varied mechanism of action at different serotonin levels. Let's discuss. In fact, it is also known as serotonin modulator stimulator. So how to remember all the mechanism of action? It is an agonist at 5-HT1A. It is a partial agonist at 1B and an antagonist at 1D. Also antagonist at 5-HT3 and 5-HT7. Also, it has serotonin reuptake inhibitor property as well. In fact, in the clinical trials, this drug showed pro-cognitive effects. That means there was improvement in cognitive functions like memory, executive function, attention. Especially one of the reason was because of 5-HT7 antagonism. Also, although sexual side effects are less, but sexual side effects may be seen with vortioxetine, and these sexual side effects in fact may increase as the dose increases. Now let's talk about SSRI and pregnancy. Can we give SSRIs in pregnancy or not? Now whenever we are giving any drug in pregnancy, one of the important things which we see is whether the drug is teratogenic or not. And usually we know teratogenic effect occurs in the first trimester. It is seen that majority of these drugs are not major teratogens. Now, when we are giving any drug in pregnancy, we also see the risk and benefit, whether it is beneficial to give the drug or it is more risky to give the drug. It is seen that in pregnancy, if a patient has depression, it may also negatively impact the growth of the child. So, it is important sometimes to give these drugs even in pregnancy. Now, let's talk about what may be the effect of these drugs in the infant if they are given in pregnancy. So, we've discussed that they are not major teratogens, but sometimes they may have some effect on the baby, especially when given in the late pregnancy, especially in the third trimester. SSRIs and even to an extent even SNRIs, which we'll discuss, may also have such effects. So, the first important effect we'll discuss is poor neonatal adaptation syndrome, PNAS. Now, this is a short-term neurobehavioral effect in the newborns, and it includes symptoms like there is poor muscle tone, the child is having sleep problem, there is shaking of the body, crying, sometimes crying less and sometimes crying a lot, irritability, seizures can occur, hypoglycemia can occur. And this in fact may represent discontinuation syndrome. So, the infant suddenly is devoid of the SSRIs which he was receiving from the mother's blood in pregnancy. So, this may represent discontinuation syndrome. Also, another important finding which may be seen in the infant is persistent pulmonary hypertension of the newborn. So, these are some important findings which have been seen in babies born to a mother who was receiving SSRIs in pregnancy. Now, there are certain smaller studies, studies have shown inconsistent findings. Some studies have shown that even neurodevelopmental motor disorders can occur, ADHD, autism spectrum disorder, low APGAR score, decrease in the gestational age, decrease in the birth weight, and even gestational diabetes mellitus, preeclampsia. These can also occur if the mother is receiving SSRIs in pregnancy, but again these are inconsistent findings and smaller studies have only shown these effects. Now, one drug, one SSRI which we should not give in pregnancy, remember P for pregnancy, P for paroxetine. It is one of the drugs which should be avoided in pregnancy as it is found to be teratogenic. It can cause cardiovascular defects. Also, remember one drug which is sertraline, which usually is one of the commoner drugs which is used in pregnancy, and even in lactation it can be used, it is seen that it is one of the drugs which is least likely to be detected in the infant who is breastfed when the mother is receiving SSRIs. Now let's talk about the second group of drug, which are the SNRI. Again, from the name we can understand these are serotonin norepinephrine reuptake inhibitors. So these drugs are increasing both serotonin and norepinephrine. And again, we can correlate this with the etiology of depression. Serotonin, norepinephrine are getting reduced and we are increasing. So these are dual reuptake inhibitors. Now these are also considered one of the first line drugs for depression. In fact, some studies have shown that they may have better efficacy in melancholic depression. But again, if you're asked to choose between SSRI, SNRI, we may still prefer SSRI. But some studies have shown that they may have good results in melancholic depression. Now let's discuss some of the drugs which are SNRIs. One is venlafaxine, then desvenlafaxine, duloxetine, remember dual mechanism of action, then even levomilnacipran and milnacipran. So these are some important SNRIs. Now the drugs which are approved, FDA approved for depression includes venlafaxine, desvenlafaxine, duloxetine and levomilnacipran. Milnacipran in fact is used for fibromyalgia. Now there is more indication for duloxetine. Many times you will see duloxetine is used for other indications as well. For example, for neuropathic pain which is associated with diabetes, for that also duloxetine can be used, and even for stress urinary incontinence, duloxetine may be used. So duloxetine has again other indications as well for which it can be used. Now coming to the side effects of these SNRIs are similar to SSRIs. So these drugs can also cause GI side effects, CNS side effects, and very important again, remember, they can also cause sexual dysfunctions. Hypertension in fact is one of the side effects especially seen with higher doses of venlafaxine. Now let's discuss the next group of antidepressant, which are the TCAs. TCAs are tricyclic and tetracyclic antidepressants. Now these block transporters of both serotonin and norepinephrine. So again, they are increasing the levels of both serotonin and norepinephrine. Now these drugs also have certain secondary effects, such as there is antagonism of muscarinic receptor. So a lot of side effects may occur because of these secondary effects. So anticholinergic side effects can occur. Then H1 antagonism, so antihistaminic side effects, alpha-1, alpha-2 antagonism can cause side effects, and even the voltage sensitive sodium channels in heart, in brain, they are also antagonized. So many side effects can occur because of these secondary effects. Now let's discuss some of the important tricyclic and tetracyclic antidepressant. Now tricyclic antidepressant, let's remember it with the mnemonic. First is CAT, clomipramine, amitriptyline, trimipramine. So CAT, DID, doxepin, imipramine, dothepin, and lastly DNP, desipramine, nortriptyline, protriptyline. So remember some of these important tricyclic antidepressants with the mnemonic CAT, DID, DNP. And we can remember the tetracyclic antidepressant with the mnemonic MAM, maprotilin, amoxapine, mianserin. So these are some important TCAs. Now let's discuss some important points about some of these individual drugs. Coming to clomipramine, clomipramine in fact is the most serotonin selective drug. In fact, this is the only TCA we will discuss when we talk about OCD. This is the only TCA which is used in the treatment of OCD, obsessive compulsive disorder. Next, let's talk about imipramine. Imipramine is also used for nocturnal enuresis. Although the drug of choice for nocturnal enuresis is desmopressin, and in fact treatment of choice of nocturnal enuresis is behavioral techniques such as Bell and PAD method. Desipramine in fact is the most norepinephrine selective TCA. Now coming to the tetracycline, remember amoxapine, it also blocks D2 receptors. So we have discussed when we talked about antipsychotics also block D2 receptors, and many side effects such as EPS may also occur with amoxapine. Also, just to remember, have a good pharma knowledge, you can remember there is one bicyclic antidepressant as well, which is viloxazine. Now let's talk about some important side effects of TCA. So one is anticholinergic side effects. As we discussed, it blocks muscarinic receptor. So patient may develop dry mouth, constipation, there may be delirium, blurred vision, urinary retention can occur. And these drugs should be avoided in narrow angle glaucoma. exacerbate the condition, and also in prostate hypertrophy. These drugs also have cardiac side effects. It can cause tachycardia. There is flattening of T wave, prolonged QT interval, ST segment depression. So a lot of ECG changes can occur, and even arrhythmias can occur. Again, we have discussed that it blocks voltage gated sodium channels, so even arrhythmias can occur. Then neurological side effects can occur, such as tremors. So fine rapid tremors can occur as side effect. Even seizures can also occur. Amoxapine we have discussed, it also blocks D2 receptor, so EPS can occur, and also because of blockage of D2 receptor, even galactorrhea can occur and also can cause gynecomastia. Then other effects such as autonomic side effects can occur, such as postural hypotension, again because of blockage of alpha-1 receptor, and certain other side effects like sedation, weight gain, these can also occur with TCAs. Now the next important topic which we'll cover in TCAs is TCA toxicity. In fact, this is one of the important topics which is repeated again and again in the exams. So when we talk about TCA toxicity, the effects can occur in CNS, CVS and ANS. Now in CNS, patient may develop confusion, coma, convulsion, seizures can occur, and even respiratory depression can occur. In CVS, hypotension can occur, ECG changes can occur, such as increase in the PR interval, QRS complex, there may be increase, so more than 100 millisecond, even QT interval is prolonged, AV block can occur, and right axis deviation can also occur. Arrhythmias may also be seen with CVS symptoms in the TCA toxicity. Coming to ANS, dry mouth, blurred vision, urinary retention can occur. Again, very important to remember, hyperthermia may occur. And again, mydriasis, remember, pupillary dilatation may also be seen in TCA toxicity. Now, a lot of time we see that there is metabolic acidosis, which is secondary to tissue hypoxia, and also because of cardiovascular abnormality because of seizures. So in the treatment, one of the important modalities of treatment is serum alkalization, and for serum alkalization we use IV sodium bicarbonate. And of course, in such patients, supportive management is also done. ECG monitoring is also done, as we know that ECG changes, arrhythmias can occur, and the unabsorbed drug is removed through activated charcoal. So activated charcoal also has a role. Hemodialysis usually is seen to have not much role because the drug has a high volume of distribution. So hemodialysis may not have that much role. So if the question is asked, least useful for treatment of TCA toxicity, sodium bicarbonate, diazepam. Diazepam again we can use if seizures are there. Then antiarrhythmic drugs like lidocaine, that can be used because arrhythmias can occur. Hemodialysis usually has not much role in TCA toxicity. And in fact, sodium bicarbonate alkalization we use, especially there is increase in the QRS interval. Now let's talk about the next group of drug, which are the MAO inhibitors. These are monoamine oxidase inhibitor. In fact, these are the one of the first class of approved antidepressant. Now MAO enzyme basically it metabolizes monoamines like serotonin, norepinephrine, dopamine. Again, we know all these are reduced in depression. So if we inhibit the enzyme which is metabolizing these monoamines, what will happen? There will be increase in the levels of these monoamines. So these drug inhibit the metabolism of these monoamines. Now MAO enzymes are of two types. One is MAO-A. It is basically doing metabolism of all the three, serotonin, norepinephrine and dopamine, and MAO-B, it is metabolizing only dopamine. So let's discuss some important MAO inhibitors. So there are three categories of drug. One is non-selective MAO inhibitors. Second is REMA, that is reversible inhibitor of MAO-A. And third is selective MAO-B inhibitors. So how to remember? We can remember. So when we enter MBBS, we are having knowledge of all the subjects. So we have a general idea. So we are getting ideas and tips of all the subjects. So the non-selective MAO inhibitor, remember TIP, that is phenylcypromine, isocarboxazide and phenelazine. And then we do specialization, we do MD. So MD, remember M for moclobemide. And when we do super specialization, or then we are working as a SR, then remember salazilin and rezagilin. And remember, salazilin, it is also available as a transdermal route. So it is one of the MAO inhibitors which is also available as transdermal route. It is also used in management of Parkinson disease. Now, in MAO inhibitors, remember one important reaction which occurs, which is known as cheese reaction, also known as tyramine-induced hypertensive crisis. Many times questions are asked on this. So, a patient who is taking MAO inhibitors, he eats certain food which contains tyramine, for example, cheese, beer, fish, or red wine. So, he's consuming MAO inhibitor and he also consume tyramine-rich food. Now, what happens? Tyramine is basically sympathetomimetic and it is metabolized in the gut by the enzyme MAO. Now, when we are giving a patient MAO inhibitor, so MAO inhibitors are given, so there is inhibition of this tyramine. So, tyramine is not metabolized and it enters the blood. Now, tyramine, as we know, is sympathetomimetic. It enters the circulation and causes hypertensive crisis. So, a patient consuming MAO inhibitors and takes tyramine-rich food may come to the emergency with hypertensive crisis. So, this is what is known as cheese reaction or tyramine-induced hypertensive crisis. The treatment is we use phentolamine, which is an alpha antagonist. Now, let's talk about certain atypical antidepressants. So, atypical means that they have slightly different mechanisms of actions. So, let's discuss some important drugs under this. First, we'll talk about the SARI group of drugs. So, these are serotonin antagonist and reuptake inhibitor. So, they are antagonist at 5-HT2A and even to an extent at 5-HT2C and also have serotonin reuptake inhibitor property. Now, one drug under this is trazodone. Now, trazodone can cause sedation and in fact, it is used in the treatment of insomnia. So, many times patient with depression having insomnia, sometimes drugs like trazodone can be used because it will also help in the management of insomnia. Now, one particular side effect which is, again asked commonly in the exam, it can also cause priapism. That is a prolonged painful erection. So, one of the drugs causing priapism is trazodone. Now, another drug in this category is nefazodone. Nefazodone is not much used now because of hepatotoxicity. Now, let's discuss another atypical antidepressant and you can remember it with this mnemonic NASA. What is this NASA? These are noradrenergic and specific serotonin antidepressant. So, noradrenergic effect, it increases serotonin as well as norepinephrine because of antagonism of central presynaptic alpha-2 receptor, and the specific serotonin effect is that it increases serotonin specifically by antagonism of the postsynaptic 5-HT2 and 5-HT3 receptor. So, one important drug. So, remember NASA went to moon. So, one important drug in this NASA category is, remember, M for mirtazapine. Now, mirtazapine has certain side effect. Most common side effect with mirtazapine is sedation. It can also cause weight gain and also can cause agranulocytosis. Now, one important side effect which is not usually seen with mirtazapine is sexual side effect. So, many times when patient on an antidepressant coming to us with sexual side effects, so many times this question is asked, what drugs we can use? One of the drugs which we can use in such situation is mirtazapine. We'll also discuss one important drug which can also be used. So, this is the NASA group of drugs which we have discussed, mirtazapine. Now, let's talk about next drug which is NDRI. What is NDRI? Norepinephrine dopamine reuptake inhibitor. So, now this drug is increasing both norepinephrine and dopamine. So, we know dopamine is also reduced in depression. So, this drug is increasing dopamine as well. Now, one important drug in this category is bupropion. Again, bupropion is one of the drugs which is again asked in MCQ exam. So, let's discuss important points. Now, this drug has low risk of sexual dysfunction. So, again, such questions have been asked again and again that antidepressant is causing sexual dysfunction. Which drug now we can switch to? So, bupropion is one of the drugs, and if bupropion is not there, then even mirtazapine we can use. Also, it has low risk of sedation and weight gain. Remember, if we compare it with mirtazapine, mirtazapine caused sedation and weight gain. So, this drug even has a low risk of these two as well. Now, why these effects are occurring? Because it is not acting on serotonin. So, especially sexual dysfunction we know occur because of serotonin. So, this drug is not affecting serotonin levels. But now, let's discuss some important side effects with bupropion. One is it can cause insomnia. So, many times, when we start this drug, we give it in the daytime. tremors can occur, nausea, and even dry mouth. Also, seizures can occur, especially at higher doses. So it is a dose-related side effect. Seizure can occur. So in a patient who has risk of seizure, for example, a patient who is a known case of epilepsy, we would not give bupropion. Also, one important condition where we would avoid bupropion. Remember, B for bupropion. So we will also avoid bupropion in bulimia nervosa. In bulimia nervosa, which is an eating disorder, we'll discuss that a patient is having episodes of binge eating and followed by purging. Because of repeated vomiting, patient may have electrolyte imbalance. So electrolyte imbalance can increase the risk of seizure, and if we give bupropion, the risk of seizure further increases. Even in anorexia nervosa again is a eating disorder which we'll discuss. In that as well, we should avoid bupropion because in anorexia nervosa, the patient is restricting himself or herself taking food. So again, there is electrolyte imbalance and seizure risk is again increased. Now let's discuss some other uses of bupropion, FDA approved uses. One is it is used for smoking cessation. So antidepressant used for smoking cessation again is bupropion. Also now it is approved for preventive treatment of seasonal affective disorder. It is the only antidepressant which is approved for preventive treatment of seasonal affective disorder. That means in the autumn, while the person is well, this drug is given to prevent risk of depression in winter or fall. So it is also used for this indication. Now also there are certain FDA approved combination of bupropion. One such combination is bupropion and dextromethorphan, which is approved for MDD, major depressive disorder. Even bupropion naltrexone is approved for treatment of obesity. So these are some combinations also which are approved for bupropion. Now let's discuss the next drug, which is agomelatine. So as the name suggests, it is affecting melatonin. It is M1, M2 agonist. Also remember it is 5-HT2B, 2C antagonist. So agomelatine is also an antidepressant. Now let's talk about augmenting agent. Now when we are treating a patient with depression, first we start the first line drugs. And suppose these first line drugs, they show no improvement in the patient. So then the next line of approach, the second line of approach we have is either we can increase the dose of the drug which we are giving, or we can switch the patient to a different antidepressant. This may be from the same class or from a different class. And one more strategy which we have is this, what is known as augmenting agent, or sometimes also referred to as adjunctive therapy. So along with the antidepressant which we are giving, we may add some other agents as well to increase or augment the effect. So let's discuss some important augmenting agent. First is lithium. Lithium is a mood stabilizer which may also be added with the antidepressant to increase the effect. Also atypical antipsychotics may also be used as augmenting agent like quetiapine, aripiprazole. Studies have also shown olanzapine, risperidone. These may also have certain improvement in the patient. Even thyroid hormone, that is triiodothyronine T3, that can also be used as an augmenting agent. We discussed the role of hypothyroidism in depression. And also we can add a second antidepressant with a different neurotransmitter action. So along with the antidepressant, we may add one more antidepressant. For example, along with the SSRIs, so patient is on SSRIs, we can also add drugs like bupropion. So now it has a different action, so that can also be used as an augmenting agent. Now let's talk about some newer agents which are getting approved. So one such novel agent we'll discuss is S-ketamine, which is as the name suggests, S-enantiomer of ketamine. In fact, even ketamine has been used in studies. Especially it is used as a IV drug. It can also be given with different routes. So ketamine, in fact, it is used for treatment-resistant depression when 2 or more antidepressants are not showing effect in the patient. Then ketamine is shown to have a good result. And we know ketamine has, in fact, a rapid onset of action. Action may start within 24 hours of administration. But again, it is not approved. So let's discuss S-ketamine, which is a S-enantiomer of ketamine. Again, we know ketamine is an anesthetic agent as well. Now, S-ketamine, as ketamine, the mechanism of action is it is a NMDA antagonist, that is N-methyl D-aspartate antagonist, which is a glutamate receptor. And this S-ketamine is available, is given as nasal spray, and it is approved by the FDA for this indication, treatment resistant depression, that is lack of response to two different antidepressant along within conjunction with the oral antidepressant. So along with oral antidepressant, S-ketamine may be used. And also this is also now approved for a patient with MDD with acute suicidal ideation or behavior. Even for acute suicidal ideation or behavior in MDD, S-ketamine may be used. Now, because it has a risk of abuse, it should be self-administered under the supervision of doctors. So it should not be given without supervision. And after the administration, the patient should be observed for at least 2 hours because of side effect like sedation, dissociation can occur with S-ketamine. Now let's discuss another group of novel agents which are approved by the FDA. These are GABA modulators. So we'll discuss two drugs. One is brexanolone and another is uranolone. Both these drugs, these are GABA A receptor positive allosteric modulators. Now, brexanolone is a drug which is given through IV infusion, and over 60 hours this drug is given, while uranolone, relatively newer drug approved in 2023, is an oral drug. Now, from the name itself, we can see nolone. So, these drugs in fact are synthetic analog of neuroactive steroid allopregnanolone, which is reduced in pregnancy post-delivery. In fact, these two drugs are approved for one indication, which is postpartum depression. So these drugs are specifically approved for postpartum depression. Again, these drugs also have a rapid onset of action. Now, one side effect which we can remember for these drugs is drowsiness. So again, you can remember, in cartoons when someone is sleeping, there are a lot of Zs. So Z, zuranolone, remember one important side effect, in fact, even for brexanolone, is drowsiness. So one should advise the patient not to drive or engage in any potentially hazardous activity at least 12 hours of administration because it impairs the ability, it causes drowsiness. Now another new drug which we'll discuss is japirone. In fact, this is one of the latest antidepressant which has been approved for depression. Now how to remember? Remember, in the end, one is coming japirone. In fact, its mechanism, it belongs to the same category of drug which is buspirone. But buspirone is not approved for depression yet. Japirone is of the similar class which is approved for depression. So this drug is the latest, one of the latest antidepressant approved for MDD. So as the name suggests, japirone, it is an agonist, partial agonist of 5-HT1A. Now it is contraindicated in patient with prolonged QTC interval more than 450 millisecond or with congenital long QT syndrome. In fact, when this drug is given, ECG, regular monitoring by ECG is done. So you can remember ECG. So ECG is regularly done when japirone is given. Now, there are certain newer agents which are being studied. Again, they are not approved, but even certain psychedelic agents are also being studied, such as the psilocybin, the magic mushroom. So for resistant cases, a lot of studies are being going on for these psychedelics, and many studies have shown some positive results with psilocybin and even LSD, MDMA. Again, these are psychedelic drugs, hallucinogens we'll discuss in substance use disorder. They are also being studied for management of depression, not yet approved for any condition. Now let's talk about some other phenomena associated with some of these antidepressants. First, we'll talk about serotonin syndrome. Now, as the name suggests, serotonin syndrome is telling us that there is an increased concentration of serotonin up to a toxic level. So sometimes when there is concurrent use of SSRIs, so SSRIs will increase serotonin, and with other drugs which also increase serotonin like MAO inhibitors which inhibit the degradation of serotonin, L-tryptophan which increases the synthesis of serotonin, lithium also again has serotonin agonist property, and even other antidepressants like TCS which also can increase serotonin. So if such drugs are given together which increase serotonin, sometimes the concentration may be up to a toxic level. So various effects or various symptoms can occur. So in serotonin syndrome, you will get a history of drugs which are serotonergic drugs. Patient complaining of diarrhea, there is restlessness. Then patient may also have other symptoms like extreme agitation, hyperreflexia, autonomic instability may be there. Then CNS effects like myoclonus, seizure, hyperthermia, rigidity, even delirium, coma, cardiovascular collapse, and even death can occur. Now, sometimes, we have discussed even in antipsychotic NMS, neuroleptic malignant syndrome. There also we may have such effects like hyperthermia, rigidity. Again, how to differentiate? First, see what kind of drugs the person is having. There, the patient is taking dopamine antagonist drug. Here, the patient is taking serotonergic drugs. And some of the important symptoms like diarrhea, hyperreflexia, myoclonus, again, these are pointing more towards serotonin syndrome. Now, how to manage serotonin syndrome? Again, supportive care is required. Hyperthermia, cooling is done. Then we can use agents like cyproheptadine, which is a 5-HT2 antagonist. So this is serotonin syndrome. Now let's discuss one more phenomena, which is discontinuation syndrome. As the name suggests, patient is taking a drug and suddenly the drug is stopped. So abrupt discontinuation can lead to certain withdrawal symptoms. Now usually this is seen with shorter acting drugs, drugs which have a shorter T-half like venlafaxine, fluvoxamine, paroxetine. And they're not seen with longer acting drugs. One of the drugs with the longest T-half is fluoxetine, so usually not seen with such drugs. So let's discuss what are the symptoms seen in discontinuation syndrome. We can remember with the mnemonic finish. So patient after abruptly stopping the drug will complain of flu-like symptoms, lethargy, weakness, there is headache. Patient may report of insomnia, nausea, there is imbalance, dizziness is there. Sensory disturbance like paresthesias, tingling sensation on the body. Hyperarousal symptoms like there is a rebound anxiety, there is irritability. So this is suggesting us discontinuation syndrome. Now how to prevent it? Again, we can prevent by tapering the drug rather than abruptly stopping the drug. So we can taper the drug. And one of the methods of tapering is X method. So here what we do is cross gradual tapering of the initial drug while adding the second drug. So suppose we have to start another drug. So we decrease the drug and we gradually increase the other drug. So this is one method, X method, which is used. So gradually tapering and then stopping would prevent discontinuation syndrome. So these were some important drugs, antidepressants, which we use for depression. So this was about various antidepressants and certain phenomena associated with them. Now let's talk about another important pillar in the treatment of depression, which is psychotherapy. Now psychotherapy we treat using various psychological methods. Sometimes we refer to as talk therapy, but it is not simply talking. These sessions are conducted in a structured manner. And let's discuss the therapy which has shown best evidence in depression, which is cognitive behavior therapy or CBT. Now, we have talked about this in etiology, cognitive theory of depression, that in patients with depression, there are cognitive distortion, faulty thinking. Also, we know that patients with depression have certain maladaptive behaviors. So, as the name suggests, cognitive, we are using cognitive techniques. Behavior, we are using behavior technique to correct cognitive distortions and maladaptive behaviors. Now, also, in fact, there are newer modifications of CBT which are also being used. One of such modification is mindfulness based CBT. So mindfulness, again, it is the concept, which was given by Buddha. So what is mindfulness? Mindfulness is basically observing your sensation, your thought, and accepting them as it is without being judgmental. So mindfulness based CBT is also used nowadays. Next is interpersonal therapy. Again, as the name suggests, interpersonal means in between relation. So here the focus is on patient's current interpersonal problems, the relationship problems. So resolving the conflicts, increasing the communication. So that is being done in interpersonal therapy. Then there are other therapies like family therapies, different family members, important family members are involved. Psychoeducation is a very important part of family therapy. Then only behavior techniques sometimes can be used, so behavior therapy, and even psychoanalytically oriented therapy, wherein we are going into the unconscious conflict, childhood memories, those are also targeted. Sometimes this can also be used. So these are some of the therapies which may be used in depression. Now, there is one interesting digital therapy which has now been approved by FDA. Nowadays we are seeing, there is digitalization all over the place. We have Digital India. So even in the treatment there is digitalization. FDA has approved Rejoin, previously known as CT152. So this is the first prescription digital therapeutic to treat MDD. In fact, it is it's a mobile software app. So in this, basically there are brief therapy sessions are there, training exercises are there, which are based on CBT. So these can be done even digitally. So this is the first prescription digital therapeutic which is approved for MDD, and it is approved as an adjunct to outpatient taking antidepressants and who are 22 years and above. So for those, even this can be used. Now let's talk about the treatment of choice for depression. We know drug of choice is SSRI, therapy of choice is CBT. So if you're asked treatment of choice of depression, remember it is combination. It is seen that drugs and therapy together have shown higher response. But again, clinically we have seen even a single therapy, that is drugs or only psychotherapy alone, is sufficient for most of the patients. So many times we may not use combination, but if you're asked which is the best is combination. Now if you're specifically asked for mild depression, now remember mild depression, when the symptom severity, number of symptoms is less, also the impairment of functioning is left. In those situations, we may just use CBT. So sometimes, and even for younger patients, in children, we may start with CBT. And if it is asked for moderate to severe, then we can use combination. If you have to choose one, then you can say drugs plus minus CBT. So if combination is there, that may be a better answer, or you can choose drugs. So, and also in recurrent depression, more severe resistant cases, we may use a combination. Now let's talk about certain other somatic modalities which are used in the management. So we'll talk about certain neurostimulation techniques like ECT, TMS or VNS. Let's discuss some of those neurostimulation techniques. So first is ECT, electroconvulsive therapy. As the name suggests, we are giving electric current, as you can see in this image. So electric current is given through these electrodes on the scalp, and it produces convulsion or seizure. Now, one of the important indication for ECT in depression is depression with suicidal risk. In fact, it is the preferred treatment in patient with suicidal risk. Now, a patient is having suicidal ideation or is planning to attempt suicide. Now, it's an emergency. Now, drugs therapy, of course, we will start, but we know that will take time. So, we don't have time. So, usually it is seen that ECT has shown very good results in patients with depression with suicidal risk. Also remember, suppose there is a pregnant female who is suffering from depression and has suicidal risk, there is suicidal ideation. Again, in those individuals, remember that pregnancy, also in pregnancy we can give ECT. So pregnancy is not a contraindication for ECT. Of course, we will, we can monitor the fetal well-being, but we can give ECT in pregnancy. So important to remember that for depression with suicidal risk, ECT may be preferred. Then there are other indications like severe depression with stupor, and in fact we have also discussed, with catatonic symptoms we have talked about. So depression with catatonic symptoms may also show response to ECT. Psychotic depression, again for psychotic depression we can start with antidepressant and antipsychotic, but ECT may also show good response. Even depression which is refractory to other modalities, there also, so in treatment resistant depression, there also we can consider ECT. Now let's discuss another neurostimulation technique, which is transcranial magnetic stimulation. Now here, as the name suggests, we are using magnetic energy. So uses short pulses of magnetic energy which stimulates the nerve cells. In fact, it is seen repetitive transcranial magnetic stimulation, RTMS, which is used. So there is a repeated changing of the electric field which produces focal secondary electrical currents, electrical stimulation to particular cortical regions. Now, if we compare TMS with ECT, we can see that here it is non-convulsive, no seizures are produced, no anesthesia is required. We know ECT now we do as modified ECT under general anesthesia and muscle relaxant, but here, as you can see even in the image, the person is fully awake. So there are no anesthesia required, safe side effect profile is there. So for ECT, we know one of the common side effect is transient amnesia may occur, but here the safer side effect profile is there and no cognitive side effects, as compared to ECT. Now, FDA has approved TMS for patients who have failed to achieve satisfactory improvement from one antidepressant. So then we can use RTMS. Most common adverse effect is scalp pain or discomfort. Now, the next neurostimulation technique which we'll discuss is vagal nerve stimulation. So what is done in vagus nerve stimulation? Again, this one is more of an invasive procedure. The left cervical vagus nerve here, it is identified and a electrode is put around it and it is stimulated by a pulse generator which is implanted on the chest. So there is intermittent stimulation to this vagus nerve, and 80% of these fibers, they are efferent, they are going in the brain and they stimulate a lot of serotonergic areas of the brain. So they are increasing again serotonin. So VNS may also be used in depression, especially in patients who have refractory depression. Now let's discuss some other therapy, and one of the therapy is phototherapy. Now phototherapy or light therapy we know is used for seasonal affective disorders. So we have discussed sometimes depression can occur in a particular season. So for example, depression more common in winter. So a patient is having at least 2 episodes of depression in the past 2 years only in winters, and there is no other episode in any other season. So then we'll consider it as seasonal affective disorder. So in that we can use phototherapy. So bright light is used in the range of 1500 to 10,000 lux or more with a light box, and the patient is made to sit near that for 1 to 2 hours each day. So phototherapy may be used in seasonal affective disorder. Also, lastly, let's discuss sleep deprivation. Again, this is one of the modalities which is still in the research purpose, not yet approved. So as you can see from the name, we are depriving the patient from sleep. So we're not allowing the patient to sleep, and it has shown significant but transient benefits, and the positive results which occur usually, it is seen that they are reversed by the next night of sleep. So sometimes, again in research, sleep deprivation is also being considered. So these were some important treatment modalities for depression. Now after depression, let's discuss another depressive disorder, which is dysthymic disorder. It is also sometimes known as dysthymia. In fact, you can understand it like this. It is a milder form of depression. So in dysthymia, we say there is presence of mild depressive symptoms. So patient may report of sadness, sometimes may report of decreased energy, there is decreased sleep. But the symptoms, they are not enough to make a diagnosis of a depressive episode. We have learned how to make a diagnosis of a depressive episode if at least 5 of the symptoms from the criteria size caps are present for at least 2 weeks. So here the symptoms are not enough to make a diagnosis of a depressive episode, but there are milder symptoms. Now, very important to remember that the duration is for at least 2 years. We have learned that in depression it is an episodic illness, but here in dysthymia we are saying although the symptoms are mild, but they are occurring for a long time, so for at least 2 years. In children we say that the symptoms should be present for at least 1 year. So here the patient may report that the symptoms have been present for a long time. Many times you will get that history that patient may say, sir, I feel I'm depressed, since my adolescence. So many times we see that the onset of dysthymia may occur in childhood or adolescence. Sometimes it can also occur in a later age. Now also remember, since the symptoms are mild, the functional impairment is not marked, it is not severe. In depression, we discussed that the significant impairment is there in the functioning. Here the patient will tell you that he is able to do the work. So patient may say that I'm able to go to my office, I'm able to do my daily course, but I have to make a lot of efforts. It seems that I have to push myself to do those things. So this is how we get a patient with dysthymia. Now also remember, we see that there is a greater risk of dysthymia in persons who have a family history of mood disorder. So in the relatives of patient with mood disorder, there may be having greater risk of dysthymia. So let's try to understand with the help of this graph. Let us say if the patient touches this line, he is fulfilling the criteria of a depressive episode. So here you can see the patient says, sir, since the past 2 years, I am feeling sad. There are days when I feel decreased energy. There are days when I feel there is decrease in sleep, and these symptoms are continuously present for the past 2 years. So this is dysthymia. You can see here the symptoms are mild. They are not fulfilling the criteria of depression. So this is how we make a diagnosis of dysthymia. Now another interesting term in literature is that sometimes patients with dysthymia, they eventually may develop a depressive episode, and this is known as double depression. So this is a term used in literature. When a patient who is having dysthymia, then in fact develops a depressive episode. So dysthymia followed by depression. This is double depression. Also remember that nearly 40% of patients who have MDD, major depressive disorder, they also may meet the criteria of dysthymia. Now, in DSM-5, in fact, they have used a newer term, that is persistent depressive disorder. As the name suggests, depressive disorder which is persistent. In fact, in this, they have included chronic depression, that means depression for more than 2 years, as well as dysthymic disorder. So the new term used in DSM-5 is persistent depressive disorder. And usually the treatment of dysthymia is similar to what we discussed in the treatment of MDD. We can use antidepressants and also we can use therapy like CBT. Sometimes since the symptoms are milder, we can start with CBT. So these were some important depressive disorder. So this is the summary of the topics we have covered in this video. We talked about depression, we discussed the epidemiology, the etiology, we talked about how to make a diagnosis, and very important, especially for your exams, specifiers are being asked again and again, and many questions are asked on the management of depression. And also we discussed dysthymia. So you should know how to differentiate dysthymia from MDD, major depressive disorder. Now let's end this video with some MCQs. The first MCQ is, a 40-year-old patient presents with symptoms of low mood, decreased interest, decreased appetite, lack of concentration and tiredness for 4 months. Again, remember duration is very important in psychiatry. So symptoms are present since 4 months. It seems that the patient is having a depression. He had a similar episode 2 years back which lasted for 6 months. So currently the patient is having a depressive episode and a similar episode occurred 2 years back. Now the question is, which of the following is incorrect about this condition? So patient is having depression. So we have to mark the incorrect option. There is decrease in serotonin, norepinephrine, it is correct. Decrease in metabolism in the prefrontal cortex, it is also correct. Increase in REM latency, in fact, so this is an incorrect statement because we know there is a decrease in the REM latency. REM occurs early in sleep. Elevated activity of the HPA axis, that is also a correct statement. Next question. A 40-year-old female presents with episode of sadness, lethargy, decreased interest, decreased appetite for 4 months. So she seems to be having depression for the past 4 months. She also reports of hearing voices of her dead father telling her that she has been a bad daughter. So now she is also reporting of auditory hallucination. So you have to tell the diagnosis. Is it atypical depression? No. Postpartum depression, again, it is not suggesting anything related with pregnancy or delivery. It does not seem to be schizophrenia because here the primary diagnosis is depression. So the answer is, it is psychotic depression. Next question. A 26-year-old female presents with episode of sadness, lethargy, decreased interest, decreased appetite, suicidal thoughts 3 weeks after her delivery. So depressive symptoms, again, very important here. She is having suicidal thoughts. This is more going in favor of depression rather than postpartum blues. So what is the diagnosis here? The diagnosis is postpartum depression. Now let's discuss the next MCQ. A 26-year-old male working in a MNC, in a multinational company, presents with complaints of feeling sad since his early adolescence. He reports of having lack of energy to do projects in his office as well as in college days, yet he is able to complete them with a lot of efforts. He feels he is not able to enjoy other things in life as he is barely able to manage his work. So the likely diagnosis is, now first of all, appreciate that here the symptoms seems to be mild. So there are a lesser number of depressive symptoms the patient is having, and also if you see the duration, he's been having these symptoms since his early adolescence. So symptoms have been present for a long time. And also you can see here that the impairment of functioning is not very severe. He is able to manage things, but he has to push and make a lot of efforts. So what is the right answer? This is typically how we get patients with dysthymia. So here the answer is dysthymia. Next question. So this question is about the treatment. A 25-year-old patient is diagnosed with MDD, major depressive disorder, and is started on antidepressant. Which of the following is an incorrect statement? So we have to choose the false statement. SSRIs, SNRIs can cause sexual dysfunction. Yes. Bupropion is less associated with sexual dysfunction. That is also correct. MAO inhibitors with red wine, tyramine rich food can cause cheese reaction. Yes, that is also correct. TCA toxicity is treated by sodium bicarbonate. We do alkalization. That is also correct. Paroxetine is avoided in pregnancy. This is also correct. Option number D, bupropion is preferred in bulimia nervosa. No, in fact, this is an incorrect statement. We have discussed that bupropion is avoided in conditions where the seizure risk is high, such as bulimia nervosa. Which of the following is not recommended in treatment for a recently diagnosed female patient with depression? So again, we have to mark incorrect statement. Cognitive behavior therapy for mild depression, we discuss yes. For milder symptoms, we can start with CBT. ECT is not used in pregnancy for suicidal risk. This is an incorrect statement. We have discussed that pregnancy is not a contraindication for ECT. So this is incorrect. Phototherapy used for MDD, seasonal pattern, correct. Zuranolone is approved for postpartum depression. This is also true. So the answer is B. So these were some MCQs we have discussed. So always try to practice these MCQs because this will also make your theory more stronger. So before ending, the two mantras which I always give for these competitive exams: keep smiling, keep moving forward. When I say keep smiling, what does this mean? Now, this journey of our competitive exams, requires a lot of duration, a lot of consistent hard work. And there are days when we are not in a good state. Sometimes it may be because there is a lot of changes in the exam pattern. Sometimes the date are changed, there is rescheduling. So there is a lot of anxiety sometimes during these preparation. So I always say keep a smile. Smiling will not change the atmosphere, will not change the situation, but it will change the way you are handling situations. So always make it a point to smile a few times in a day. Also, when I say keep moving forward, take one day at a time. Don't regret about the past because we cannot change it. Don't have excessive worries about the future. Only the current, the present is in our hands. So, always focus on the current moment, on the one particular present day, and keep moving forward. So this is for this video. I hope you enjoyed this discussion on depressive disorders. Thank you. May God bless you all.